Our next speaker is Dr. Alexander Vaccaro, who will be discussing patient safety in the setting of rapid transformations in healthcare.
Thank you. It's an honor to be the token orthopedic surgeon to speak today. After looking at Robin Rosenwasser's talk, I got so nauseous looking at pictures of the brain, I almost didn't make it to the podium. I was just testing the humor of the crowd, so it's going to be a tough crowd. So I was asked today to talk about innovations in healthcare management and how it relates to efficiency and to safety. And this is not my talk. That is awesome. This is not my talk. That is so cool. It is not my talk. I downloaded something else. This must have been sent in a while ago, but I'll talk off of this slide. I made a talk on innovation, but I'll just talk about where we're going at the present time. So I represent something called the Rothman Institute. It's an orthopedic group. We have 150 orthopedic surgeons at the present time. We're in Southeast Pennsylvania, and we developed an unusual relationship with our healthcare center. Years ago, we pulled away from the university. Oftentimes, when you make an effort to pull away from a university, they fire the chairman, which almost happened. And so we're an independent group that works with 4 healthcare centers, and we cover all the different areas of orthopedics as well as the sports teams, the 4 major sports teams. What sort of makes the Rothman Institute a little bit different is that we have a full-fledged fellowship program. I'm the spine fellowship director. We have 5 spine fellows, but in each area, oncology, trauma, joint replacement, foot and ankle, and hand, we have a fellowship. So we're able to continue as a private entity with a fellowship program. And this is sort of a breakdown of the different groups that we have. We have an integrated model as we move into different areas and say, listen, please come with our model, and I'll talk about a model in a second. We have 3 different options. 1 is to bring people in full-time so they're not managed by a university. 2, we develop an MSO or an MSA, which is a management service organization, where we manage for a service fee and use best technologies. Or 3, we do sort of a more distant telemedicine type of operation where we put our emblem, the Rothman Institute, on it for best practices. So those are the different ways we do it. Our joint service is sort of our flagship. If you look, the director of research is Jay Parvizi, and he has sort of shepherded over 190 peer review articles last year for a private group, which is somewhat impressive. And if you look at the orthopedic literature, we have, our Bible is a Journal of Bone and Joint Surgery. That's our Bible. Then we have Journal of Arthroplasty, and then we have Clinical Orthopedics and Related Research. And a study came out last year that looked at the top universities in the country that published. And the Rothman Institute, as you can see here, had the number of publications in all 3 journals, the number of authorship, first authors, and the highest number of points per faculty member. And that's sort of a breakdown comparing to the greats in orthopedics, the Cleveland Clinic, the Mayo Clinic, and Mass General, and that goes across the board. So we're very proud of that. In spine surgery, Todd Albert was the previous chairman. I'm now the new chairman. But from an academic perspective, we have such a strong relationship with the neurosurgical brethren. Jim Harab is my co-chief in spinal surgery from the neurosurgery department, and we sort of focus on making sure we publish. Now, what is our legacy? Our legacy are the spine fellows we train, and if you look across the country, if you look at the H-index when it comes to publications, the number of peer review, where do your spine fellows go when they graduate? Do they go into private practice? Do they go into academic universities? This is a study that came out of Harvard last year that showed that most of the spine fellowship programs, that especially Thomas Jefferson, train the leaders of the future from an academic perspective. The average amount of peer-reviewed publications that you can see over a time period of 2011 to 2014 was 12, and the university with the neurosurgical department had 161 publications. So the key to understanding the future of healthcare is understanding relationships. If you're at a university and you're wed to that university, I make the argument that is great if the university is doing well. It is not great if the university is going down the wrong path. And if you look at the 5 insurance companies across the country, they're trying to make it so there's only 3 insurance companies, which is a bad thing for 2 people. Patients and neurosurgeons, because you have less negotiating power. So the focus in our group is to maintain a relationship with the 4 players that you see here: the Jefferson system, Atlantic Care, Mainline Health, and Kennedy, and we're moving up into Bergen County area. So I'm from New Jersey originally, and New Jersey is sort of an open, wild, wild west for healthcare to be better organized, and that's our goal, is to move in that direction, and that's where we stand in 2016. And for a group of 150 orthopedic surgeons, our combined income was $500 million last year. And that money gets reinvested into our research laboratories, our fellowship programs, and our education, if you look closely. Now, what makes the Rothman Institute strong is our independence. You can look at reimbursement across the board going down and down and down, and you have to maintain a viable equity position in everything we do. So we believe the future in spine surgery, we believe the future in orthopedic surgery is outpatient ambulatory care, where we manage the bundle. We cannot let universities manage the bundle. And if you follow closely what has happened with the joint arthroplasty, it's the first bundle that's been organized by CMS. They've given that control over to the hospital, which is the biggest mistake. But we can control ancillary services, we can control the hospital, and this is just an example of the different services that we can control. Now, technology, one of your key speakers this year is a technological expert that will talk to you today on the importance of big data, and we stand strongly behind big data, and it's important in understanding where we stand. We have 5 bundles that we've negotiated. We have 3 retrospectively and 2 prospectively. The problem with the prospective bundle is that you introduce the concept of risk. You have to be able to understand every single cost. So to do that, we use something called real-time cost accounting. Everyone that comes in contact with a spinal cord injury patient, a patient with an orthopedic joint problem, we look at the salary of that person who touches that patient, we look at every device used, every bandage, and we do cost accounting to find out what the cost is. And then we negotiate with the insurance companies, and we use reinsurance to take a look at those outliers that don't make any sense. So that's sort of the goal, and we do that through big data. And you'll have a speaker, and that allows us to take the full breadth of information that we have, bring it together to show the insurers, to show CMS, to show the hospital what our quality is, how we educate, what our 30-day readmission rates are. We are able to navigate patients to make sure they're healthy. And this is just a typical example of our investment. As a private group, over the last 5 years, we invested $60 million in software in order to understand the future of healthcare. OBIRD is our patient outcome, and we sort of have an open portal where patients can see their medical records live. We send them emails, they populate the data, it comes back in, and we look at that data and we do a risk assessment to look at their comorbidities to find out, should that patient go to a university? Should that patient go to a physician-owned hospital? Should that patient go to a community hospital? We use outpatient online physical therapy units off of Comcast. Comcast is my cable. We have something called the Rothman channel, where you had a total knee replacement, your doctor's face comes on a mannequin, and it tells you what to do, and we put sensors on your thigh and your ankle, we do range of motion, so you don't have to come back again. And this is just a waste of time, because if you look at the bundle for orthopedic care, 47% of that care is post-hospital discharge. You, the neurosurgeon, makes 6.7 to 9.3%, and the hospital makes 23%. So we have to look at it across the board to find out where the money is going. So this sort of new technology phenomenon where we can get a feedback on patient satisfaction. If the scores come back low, we then contact the patient and ask the patient to come back and see us. The next thing is we have to decrease readmissions and we have to decrease hospital ER visits. So we set up a network of over 300 urgent cares, and they get these best practices. They have our phone number, so when they come in, we have a 24/7 phone line. So wherever you are in Delaware, New Jersey, Pennsylvania, you go into an urgent care, we can use telemedicine to look at the wound, we can talk to the patient, and most importantly, keep them out of the ER because we're getting fined for that. That allows us, as I said before, to develop these bundles, and the toughest negotiator is the United States government. Now, they've figured out how to save money for total arthroplasty, but I'm a spine surgeon, and they haven't figured out how to save money. And I went down to CMS recently, and they said, we don't get it. We can't get this to work for spine surgery, because the cost of care for spine surgery isn't you, the spine surgeon. It's all the stuff that happens before they come to us. It's the unnecessary injections, it's the traction, it's the opioids, it's all the things that the non-operative guys do to our spine patients. So we're coming up with an understanding with CMS to really come to an understanding of how that episode of care should be managed. And all of our partners in the episode are benchmark partners. We have people who do risk assessments. We understand that the cost of care is what happens afterwards. So we want partners. We want the therapists that are inexpensive and cost effective. We want to make sure our primary care physicians aren't giving narcotics to our patients. We want to make sure that they go to the appropriate person. And we have navigators that say, okay, we've done a risk assessment. We've looked at your Charleston morbidity score. You don't have to go to Thomas Jefferson University. A total joint arthroplasty costs $17,000 more at Thomas Jefferson University than it does in a physician-owned hospital. So that's crazy. So we look at the risk assessment and make sure people go to the universities that are cheaper with the facilities. It's the point of contact that is cheaper. And if you look at the commercial market data, this is how much money can be saved if you look at the percentile care. We can save an insurance company $20,000 per arthroplasty if we put them in the right place. Lumbar spine fusion, the same play. We can do outpatient spine surgery. Minimally invasive techniques allow us to do so much more. Don't do it at a university. Don't do it at an expensive community hospital. Do it in an ambulatory surgical center, and you'll save money. And this is what I said before. Look at that, 12,000, 43.5%. That happens after the patient leaves your door. So why should the hospital control that bundle? You, the neurosurgeon, should control that bundle. And we do the same thing for spinal fusions. 60% of the cost after a lumbar spine fusion occurs when the patient leaves the hospital. So we have to understand the risk factors. This is just an example of what we do. We have a patient populate the EHR. We have a red light, green light. We put them through a program. If it's a red light, they can't get operated on. They have to be optimized until they turn green. And this is just what happens. We have navigators that are assigned to each surgeon, and the navigator gets 5 or 6 surgeons, and each navigator manages 1,500 patients. And he goes through this whole algorithm and says, okay, you're safe now to proceed with an elective spine operation, and you have to go to this facility. And then we learn more about our patients through the system, and they tell us, Dr. Vaccaro, you can't take that patient to surgery. That patient is obese, that patient has congestive heart failure. The risk of that patient developing a postoperative complication is 1.5 standard deviations. They have to be optimized. So as long as it's not an emergency, we have the ability through this technology to better navigate the patient. So this is just an example of what the future will be. And we have contracts with everyone that we work with. The physical therapists, we only want 10 visits. The people giving the medication, they have to fit into our algorithm, and if they don't fit into our algorithm, we don't use them as a quality provider. So this is a way that we're using now to look at how we do. I want to conclude by looking at how we manage our physicians. This is just a dashboard of the doctors that work with us. I get this reading every day. Green is a good thing, red is a bad thing. And I look at where patients should go after surgery. I look at something called a physician intensity score. I look at how quickly does that surgeon escalate to studies? How quickly does that surgeon escalate to surgery? How does he prescribe medications? Does he use generic? Does he use the right medication? Does he give the patient narcotics? And the last thing is, how does he use his consultants? Does he use his consultants on a timely basis? And I get a report card. And if you have a lot of green, I'm happy. If you got a lot of red, you come into my office and we sit down. Why you're practicing this way? And it allows you sort of to modify your behavior. And these are dashboards that we get every week. So it allows us to really make care more affordable down the line. And this is just an example. I took 2 of my joint surgeons and I showed them these things. One joint surgeon can do an operation for 12, the other one 6,000. And I'm like, why does that happen? And people have cultures, people come out of training centers where they're taught to do things certain ways, and this can be changed. So we get this whole cost care analytics so we know exactly what to do. And then we stratify our surgeons in such a way that we get a better understanding. So what is the future for neurosurgery? I can't talk about aneurysms because I get sick, but let's talk about spine surgery. The future of spine surgery is minimizing, number 1, unnecessary surgery, 2, minimizing the cost, controlling the bundle and not letting the government or the university control the bundle, and come up with sort of population health management theories that allow us to deliver care that's effective, safe, and will allow us to continue to control our future. Thank you. I have one disclaimer, and I have to be honest. This was not my talk. I must have given the wrong pen drive, and I did it because I'm an orthopedic surgeon and I'm stupid. But I like this talk. Thanks.